Hi, this is Brian Wormers. I'm recording a lecture for University of Sioux Falls for pediatric nursing, and this is the pediatric variation of nursing interventions. So these are some of the objectives. So we're going to talk about consent and assent, talk about emancipated minors. We'll talk about caring for children and procedures, including surgery. We'll talk about therapeutic procedures with this. We'll talk about play with that. We're going to talk about general hygiene. We'll talk about feeding techniques. We're going to talk about reducing temperature, fever. We're going to talk about infection control. And lastly, we'll talk about some of the tricks that we can use with safe methods for medication administration. So as we're working with pediatric population, so we want consent as much as possible. But if you think about it, with consent, they have to be able to give consent. That's usually age of 18. That doesn't fit most of our pediatric population. They need to be able to make an intelligent decision. Well, that's questionable in some of our patients. They have to be voluntary. What happens if most pediatric patients would prefer not to be in the hospital? And so with these consents, yes, we need to obtain it from the parents, and that's one of the big things that we do for a parent or legal guardian. If there's an emergency situation, of course, we were acting in the best interest of the patient. At that point in time, we wouldn't necessarily need consent. But when we can, we really do try to do these things. Separate consents for different procedures and skills. So you might need one from surgery, you might need one for anesthesia, you might need somebody from putting in a PICC line before the surgery. And so every situation we do need consent for. Photographs, depends if you're taking those photographs. Oftentimes you need consent to take the photograph, and so just be aware of some of these things. So older children and kids that can understand, oftentimes we want their assent, and so you can look at this, and this is a good discussion of it. But assent means that you've got their blessing as well. And so the parents might be the ones that give the informed consent, but you want the child on board as well. And so life is best when those two align. It gets really kind of messy if the kid doesn't want something done and the parents do. Or vice versa. But oftentimes that turns into having to have good conversations with both the family and the patient. Someone can consent to some of the treatments if they are under the age of 18, so sometimes birth control under the age of 18 or different situations like that. State law really is the one that dictates that, and unfortunately state law varies from state to state, so what happens in South Dakota might be different than Minnesota, and so realize that those are some of those big things. Kids can also be emancipated, so you can look here to see what an emancipated minor is and when that happens. A good situation of this was I had a physician who said that they were caring for a child who was in Michigan at the time, came in with belly pain, who was 16 years old. Mom brought the child in, they're working him up in the emergency department, and lo and behold, the child was pregnant, gave birth. Well, at that moment in Michigan, birthing a child emancipates you. And so at that point in time, the 16-year-old, who is maybe still a child, but decided that they're emancipated and they wanted the grandmother out of the room now, or the now grandmother out of the room. And that was a hard discussion, but that was the legal ramifications of that. And so they had to kick that grandmother out and allow that. In the state of South Dakota, it gets a little interesting, and you'll probably talk about it in maternal, but with the 16-year-old, they are responsible then for the care of that child, but they don't have care of themselves yet. And so their parents still have the right for informed consent for the 16-year-old, which gets really weird sometimes. And that's what that's talking about, is they might not be of legal age, and who can make decisions for them or for their children, and it gets interesting. So there usually are exceptions for things like they can seek help for STIs and substance abuse and contraceptive, but that's It's a big but, and it varies state by state. So wherever you're working, you're going to have to figure that one out. Prepping for diagnostic and therapy procedures. Once again, do this as much as possible. Involve child life as much as possible. Talk about it. Let them ask questions. Let them see stuff if they want to. Let them touch things as long as they're not going to hurt themselves. And that can make the world of difference. But walk them through it. Let them know what to expect. The sights, the sounds, the smells. That really does help. So preparation. So really trying to establish trust with that child and that family member. Sometimes we try to not be the bad guy with our patients. So what I mean by that is, if you're caring for your patient and they've got an IV or a Foley or something like that, you might ask me to do that. That way that you keep that trust between you and your patient, and you're not seen as a bad person, so to speak. And so we'll do that very frequently. Try to have parental presence and support there, but don't make them the bad person by holding them or doing procedures. Choose your words carefully. We talked about that in a different presentation, but look at those words. Incision or cut can be a little bit more threatening than it's like a special opening. Think about sedation, pain meds, localize lidocaine or whatever to try and help with pain and distress. Involve that kid, give them simple choices. Do they want to watch this movie or this movie? Do they want to watch something or read a book? Do you want to do a Where's Waldo? Give them a choice, but don't give them a choice if they don't have one. Provide distractions. Like I said, child life is amazing, and you want them on your side. And then allow expression of feelings. It's all right for them to cry. Don't be like, oh, you can't cry because the baby's sleeping next door. Allow it. Let them to express it. It's their way to cope. Unless they're having such a fit that they're going to hurt themselves, then of course we got to stop that. But if it's all right that they're scared, it's all right that they're nervous, it's all right to cry when it hurts. So at the end, tell them that they did a good job, tell them that you're proud of them, maybe give them a little bit of a prize, and work on that. Try and let them play as much as possible throughout the procedures, as much as possible while the hospitalization. We talked about that before, but whether that's card games or dolls or going outside or going for a walk, who knows? Do whatever you can, try and let them play, let them have fun, and let them be a kid. Surgical procedures, let them see the room, let parents come back with them until they get anesthetized. There's lots of things that we can do with this one. Talk about things, have a walkthrough, have a comfort item with them. Do not lose the comfort item. Do not lose their favorite blanket. Do not lose their favorite teddy bear. If you take a comfort item with them to surgery or any procedures, that is gold, and do not lose that, otherwise so help you. But realize that we can try and minimize these things as much as possible. Also realize that kids can go through similar side effects that adults go through. So, malignant hyperthermia is a real concern. Make sure you read up on that. That's a serious thing. But yeah, walk them through. Skincare, general hygiene. We really do try and take care of the kids as much as possible, as well as we do adults. That includes bed baths. That can include giving them a shower. That can include doing their hair, combing their hair, painting nails, washing private parts, those kind of things. But we still want to care for them, and that's a part of it. Encouraging fluid techniques, make a game out of things whenever possible. They love little med cups to drink out of. If you think about kids are in an adult world in which everything is too big for them, if you have fun-sized things for them to drink out of, do a little tea set, something like that. Frequent little sips will add up quickly. And so if you can have a little tea party with their parents and, okay, every 5 minutes we're going to take a little sip, that adds up, and that does a great job. Try to do something fun like that, though. Otherwise, reward them with stickers. And sticker charts can earn prizes and toys, and oftentimes they like that. Think about the cultural and personal choices. Not everybody likes the same food. We sometimes make assumptions that, oh, kids like mac and cheese and chicken nuggets and cheeseburgers. I had a little kid from India one time, and he did not. It was weird food to him. It was over-seasoned. It was gross. And so we had his parents make food and bring it in, and that's what we fed him. And it was probably plain to most of your taste buds, but that's what he liked, and that's what he was used to. So think about that, and that we need to make those choices based on what is routine for them. Watch fluids with glucose. That can aggravate things. So if they've got diarrhea and we give them a lot of Gatorade or sugary stuff, that can make that diarrhea worse. Watch that around labs and stuff like that. We sometimes will use sweeties for procedures, but if you haven't gotten your labs yet, then you can knock your labs out of whack a little bit if you have too much sweeties before you draw the blood. So be aware of some of that stuff. Advanced diet is tolerated. Oftentimes when they're hungry and thirsty, they want to drink and eat a lot, so make sure that they don't do too much, otherwise they'll puke from that. So those small volumes over time really do add up. So with fever reduction, that's a major consideration for kids. And of course, when we got a fever, we don't feel good. So then we talk about fever reduction for that aspect of it. We give the Tylenol and Motrin if they're over 6 months of age. But trying to reduce that fever, and we reduce the fever because of discomfort, because nobody likes having a fever. But the other thing that's really important on kids is what that will do to their metabolism. It revs it all up, it burns their calories, it causes them to have expenditure of fluids, and so we try to make them comfortable, we try and keep their metabolism lower, we try to do things that will make them a little bit happier and not stress them out so much. So if they are super overheating, then of course we can use cooling blankets or other assistive devices like that. We can put ice packs to pits and privates or other things like that or along their jugular. But the bad thing is if they start having goosebumps and shivering, then that's usually counterproductive. Febrile seizures can occur. They occur in about 3% of the population, as in kids. And if they have febrile seizures, then they're more likely to have a seizure later on in their life. It only doubles. It goes from like a 3% for febrile seizure in kids to, like a 3% within adulthood as well. But typically they'll outgrow febrile seizures by age of 6. An interesting fact is that they can have a febrile seizure within 24 hours of having a fever. So they might actually start with the seizure and then get the fever later, and that's still a febrile seizure, as long as it occurs within 24 hours. But that's a concern of ours too. Safety, of course, we want to keep them safe. We want to keep them in their beds. We want to keep them safe. We want to make sure that they don't fall out and go overboard and bonk their head. Sometimes they can't tell us their name, so we need to have an ID band on them, especially if they're going to surgery or procedures or those kind of things. We have environmental concerns about, removing obstacles on the floor. Can they walk? Can they do these kind of things? Are they going to get tripped up with their IV pole? Are they going to stumble on something, fall? Are they going to strangulate with some of the cords? Are they going to choke on the Band-Aids or anything that we put in their bed? Little kids, will they put anything in the electrical outlets? So we do have to watch the environment that they're in and make sure that it's safe for them. Infection control, of course, we try to be, careful about infection control as well as we are for adults, but just realize that there are some additional concerns, especially when they start putting things in their mouth. And these little kids tend to be immunocompromised. Restraints. If they keep interrupting their care, we do have to put some restraints on them, especially like in ICU units. But make sure that the restraints that we're, being minimal, constantly checking, looking for skin breakdown, and making sure restraints are not used inappropriately. So in collecting specimens, try to be atraumatic as possible. Also look at the volumes. We can't pull the same amount of blood that we would off of an adult as we would like a 1-year-old. So we do look at that. We usually base it on weight and the volumes that we can pull off at that point in time. Realize that when we do procedures and stuff like that, we want specialized sizes for that, and that's usually smaller to fit those type of kids. Often the adults, we're always talking about pokes and doing those kind of things. In kids, we can sometimes get away with a heel poke or a finger poke, and it's less traumatic, it's easier. Nasal washing, swabs, and stuff like that are common. Just be able to explain it and comfort afterwards. Medication administration. So, I mean, everything we do in adults, we do in kids. So we can give oral medications, we can give IV medications, we can give interosseous, we can give rectals, we can give sublinguals, we can give, meds in a variety of different ways. Try and think of what's going to be the best for the kid in the way that you're going to do that. Make sure that you're not putting a medication in a big amount of fluid, because what happens if they don't drink it all? Sometimes we can make the meds taste better with some chocolate syrup, or put in it, sprinkle it on some chocolate pudding. So we really do try and do this in an age-traumatic way. We try and make it as best as possible for these kids, but we also do what we can do. IM injections, we really try to avoid these as much as possible in kids. Sometimes we can't help it, but if we can avoid a poke, oftentimes we will. This will include that, maybe we do start an IV just for this one medication that can be given IV instead of IM, because it's better to get an IV one time instead of IMs twice a day. Think about what they need, so don't always go overboard, but do they need a PIC, do they need midline, do they need a PIV, do they need tunneled catheters? Think about the length and the size that they might need with this one. IOs, we can talk about that in a little bit, but it's like an IV, but it goes into the bone. It is a great tool that's life-saving, and I really appreciate it. You will not do this procedure without additional training, but this is something that nurses can do. We can give things via G-tubes. So if they've got a G-tube, why would we give it oral? So we can do things via G-tube. And so NGs, OGs, G-tubes, J-tubes, there's lots of different places we can put different medications, and sometimes there's some differences with those. Rectal, we can give rectal Tylenol or something like that. Eye drops, similar as what we do for adults. Aerosolized therapy, so albuterol is one of the common ones, or duonebs, or different things like that. So a lot of things we can do for kids, or for adults, we can do for kids, but we just got to try and make it as atraumatic and as nice as possible. And the last slide here is maintaining fluid balance. So as we're doing this, adults are, put them at 100 or give them a liter bag of fluid or these kind of things. For kids, oftentimes we're basing this on weight. When we're maintaining I's and O's, oftentimes we'll weigh diapers, and we say that, 1 milligram of or 1 gram of weight is equal to like 1 milliliter of urine. So it's a 1-to-1 basis. So if they've got a diaper that has a net weight of 30, then we say that they lost about 30 cc's of fluid. For fluids, we don't just kind of do a normal 100 cc's an hour, 150 cc's an hour. We calculate it based on weight, and oftentimes we've got different calculators to help with this one. So the Holiday-Seeger method is this, so 100 mils for the first 10, 50 mils for the second 10, and then 20 mils. And so that's how we calculate the daily volume that we have to give, and then divide that by 24 to get an hourly rate. Oftentimes we like to cheat as nurses, and so instead of this one, we'll use a modified method, or 4-2-1 method is what they say. So this calculates it out per hour. So if you've got a child that weighs 30 kilograms, so 4 times 10 is 40, plus 2 times 10 is 20, plus 1 times per any kilo above 20, so that would be 10. So 40 plus 20 plus 10 is equal to 70. So that's how we calculate that rate. And so if the child only weighs 5 kilograms, 5 times 4 is 20, and that's our That's our fluid rates. This one is more accurate. This one is quicker. They're both close, but this one's better if you have to choose, or if the doctor wants to be very precise. Think about IV places, and kids will often use scalp or feet or other things like that, and that's kind of a skill that you'll learn and obtain within the pediatric realm. We use small things, 22, 24, or even NICU's got 26 gauge needles, and I have called up to NICU to borrow some of those or use some of those on small kids. We often will cheat and use transilluminators, red lights, ultrasounds, do whatever we can to try and make this IV procedure go as good as possible. Due to precise things, we do measure all the time, and so if you are putting a flush in after medications, often we count that flush in their I's and O's. So it's maybe a little different than the adult realm that you're used to, but any little fluid, especially on little kids, it can make a big difference. Alright, well that concludes this presentation. If you have questions on this, please reach out and contact me. I hope that some of this made sense and you can see some of the differences between adult medical surgical nursing and pediatric nursing. As you start doing clinicals, you're going to see all this stuff in practice, and hopefully it'll make sense. Alright, I hope you're having a wonderful day, and if you have questions, reach out to me and contact me.